Diagnosing temporomandibular disorders is like solving puzzles or cracking codes. The entire diagnosis is given by the patient. The only problem is that it is in his own words. The key to diagnosis of temporomandibular disorder lies in a proper history taking and clinical examination. Investigations are done only to reconfirm your provisional diagnosis or to satisfy the patient when the patient wants to check you. The most important thing to remember while history taking is to let the patient speak. Do not ask leading questions right in the beginning and do not interrupt the patient when he is reciting the whole history. The only suggestion you can give is to start from the beginning. When you ask leading questions right in the beginning, the patient often gets confused, biased, and forgets the history, and you miss out on a lot of information. The patient, trust me, will lead you to the cause and the effect himself. Sometimes as you complete the history, you won't even have to ask any leading questions, but because the diagnosis will already be there. So let the patient speak. The most important thing to remember during clinical examination is to focus on history to find out the area to examine first. The most safe way to examine is to examine the joints first, the muscles next, and the oral cavity last to avoid biases. Suppose you do not listen to the history carefully and chronologically and jump into examination. We as dentists have a tendency to look into the oral cavity first for the causes, then the muscles, and then the joints. You will have a number of findings in every patient. There will be attrition, abrasion, effractions, deflections, deviations, pain in muscles, limitation of opening, and you will be confused. The safest way is to concentrate on the patient's history and search and examine areas that he has pointed out in them. Trust me, the patient will lead you to the cause and the effect himself. The last but not the least important thing to remember is this, that you have to have a complete knowledge of all the muscle disorders, all the intracapsular disorders. You need to know what is protective co-contraction, what is local muscle soreness, what is trigger point pain, what is chronic centrally mediated myalgia, what is fibromyalgia, what exactly is myospasm. You need to know the entire range of intracapsular disorders, the inflammatory disorders, the derangement disorders, the congenital disorders, the developmental disorders. The clinical presentation of each disorder is different. How is it possible to treat any of the disorders without knowing what you are dealing with? In fact, how is it possible to diagnose any of the disorder without knowing the clinical presentation of each? Remember, there is no one treatment fits all in temporomandibular disorders. Most of the failures of treatment are because we try to fit only one treatment protocol to all the pain disorders. It is bound to fail. Have a thorough understanding of all the disorders to be able to diagnose them and treat them effectively. They do work. Understanding all these important points, now let's crack the code in this patient's history.
Hello, Karan.
Hello, ma'am.
What is your age?
23.
23. And what is your problem?
मुझे एक्चुअली यहाँ पे काफ़ी टाइम से पेन रहता था. इस रीज़न में बहुत टाइम से रहता था. अराउंड 6 साल से प्रॉब्लम रहती थी काफ़ी, बट धीरे धीरे करके प्रॉब्लम बढ़ी थी.
When the patient says that he has pain since last 6 years, it puts his pain problem in chronic pain category. Chronic pain is any pain that lasts more than 3 months and is constant. The relief in pain due to medicines is not counted as actual relief. For relief to be counted as an actual relief, it has to be spontaneous. So any patient who has pain more than 3 months and there is no pain-free period without medications, relief in pain only due to medications is said to have chronic pain. So this patient puts his pain problem in chronic pain category right with his first sentence. Look at the fingers of the patient while he describes his problem. He will tell you the current site of pain. If the patient has pain in his temporomandibular disorders, he will place his fingers right over the joint. If, however, the site of pain are muscles, the patient will move the fingers over the muscle that is most painful.
दैन डॉक्टर्स को दिखाया, सो डेंटिस्ट को पहले इस तरीके से दिखाया था. सो सबसे पहले मैं ENT में गया था. सो ENT में उन्होंने मुझे थोड़ा गांठ है ऐसा कुछ का बताया था. उसके बाद उन्होंने FNAC टेस्ट किया था. FNAC टेस्ट मेरा नॉर्मल आया था. उसके बाद भी पेन बार बार होता रहा था. सो उन्होंने एंटीबायोटिक्स दी, माइनर इन्फेक्शंस बताए, फिर उसका ठीक हो गया. एंड इन द लास्ट उन्होंने बोला ऐसा कोई मेजर इशू नहीं है, आप नॉर्मली सिकाई कर लिया करो. बट स्टिल प्रॉब्लम ग्रोथ हो रही थी, बहुत ज़्यादा प्रॉब्लम हो रही थी. फिर मैंने अलग अलग डॉक्टर से सजेशंस लिए और फिर फाइनली मैं डेंटिस्ट जो है उनको दिखाया मैंने. सो उन्होंने मुझे बताया कि यहाँ पे विजडम टूथ है, 4 मेरे अलग अलग जगह से निकल रहे हैं. जो ऊपर के 2 विजडम टूथ है वो ज़्यादा प्रॉब्लम क्रिएट कर रहे हैं क्योंकि एक साइनस से टच हो रहा है.
A history of multiple visits to ENTs, neurophysicians, psychiatrists, as the patient will tell you, and other doctors will tell you 3 things. First, that the patient might have had some medications that actually aggravated his problem because of parafunction as their side effect. Second, it can give you a hint why the pain problem converted to chronic problem. The treatment was never targeted at the source of pain, so probably the pain became chronic over time. The third gives you a hint at clinical examination. This patient tells you that some doctors suspected pericoronitis as the source of pain, swelling, and his chronic pain problems. So this is what we are going to look into during our clinical examination.
उसके बाद मुझे जॉ में भी काफ़ी प्रॉब्लम रहती थी. तो जैसे रहता था कि मैं कभी कभी पेन ज़्यादा होता था, स्ट्रेन फील होता था, साथ में इस जगह पे पूरे में स्ट्रेन और ज़्यादा बढ़ गया था. और धीरे धीरे करके क्या रहता था कि मैं खाना खा रहा हूँ, कुछ भी खा रहा हूँ तो कंटिन्यूस पेन रहता था.
Pain and strain during function will tell you whether this patient is ours or not. If there is a positive relationship between increase in pain due to function of the oral apparatus, probably this is our patient. If the patient does not relate his pain to function of the oral apparatus, probably this is not our patient. A word of caution. For patients who have history of pain lasting for years together, sometimes the pain starts in the muscles of mastication or the temporomandibular joint or any region in the oral cavity. It is prolonged because the treatment is never targeted at the source. The initial site of pain progressively heals because the patient starts limiting function because of pain. However, the continuous pain input has set in the chronic pain cycle already. The patient now has continuous pain though the original source of pain is completely healed. He slowly starts forgetting that the pain actually started from the joints or muscles or oral cavity. He just remembers pain that is diffused all over the areas. In these cases, you won't find any relationship between function and pain that the patient has presently. But on a deeper query, he might give you that it started this way where the pain increased with function in the beginning. So you have to select your cases with a little bit of Sherlock Holmes behavior. So when the patient says that his pain increases with jaw function, the source of pain might be in the joints, in the muscles, or in the oral cavity. However, when the patient says that his pain has no relationship with function, then there might be 2 possibilities. Either the patient has completely forgotten the relationship because of complete healing of the source of pain, or the source of pain actually lies in the cervical spine or in some trigger points in the muscles of the head and neck. So when he chews, opens mouth, closes it, or speaks, these sites are not stimulated and the pain does not increase. Select your cases on the basis of this relationship of pain with function. Again, look at his fingers. he is pointing over the head and neck region. This tells you the site of pain. Originally, he had put his fingers over his masseter. Now he is indicating that the site also involves his head and neck. Remember, these are the sites of pain that he is telling you. They might not be the source of pain. A history of swelling tells you about two possibilities. Either the patient had actual swelling or he had just a feeling of swelling. An actual swelling will be clinically visible to the clinician. A feeling of swelling, however, will be a patient's complaint but would not be clinically visible. Now, what could lead to actual swellings? There are two possibilities around the area that the patient is indicating. First, a swelling from intracapsular source, which can be due to disc derangement disorders, retrodicitis, capsulitis, sinusitis. This swelling will mostly be visible to a thorough clinician. The second possibility can be pericoronitis, but pericoronitis will have to have the two molars present inside the oral cavity. Second, pericoronitis usually has pain that is not constant but intermittent. The patient will also have to localize the pain intraorally in case it comes from pericoronitis. So, from the actual source of swelling, the intracapsular and pericoronitis, we can easily rule out pericoronitis. If the patient ever had actual swelling, it might be due to any intracapsular problem that he might be having at that time. Now, what if the patient just had a feeling of swelling? A feeling of swelling that is not clinically visible is a typical feature of chronic centrally mediated myalgia. Now, what is chronic centrally mediated myalgia? Suppose there is a source of pain inside the patient's joints or muscles or oral cavity. The afferent neurons from this source of pain carry impulses of pain to the spinal cord continuously, since the treatments are not provided so easily. The continuous bombardment of pain impulses from the primary afferent neuron to the second order neuron and to the third order neuron causes central sensitization. There is an overflow of neurotransmitters that leads to this central sensitization. Now, this central sensitization leads to two things. One, the continuous central sensitization will cause an antidromic release of neurotransmitters in the areas supplied by the afferent neurons. What does that mean? The primary afferent neuron that was carrying painful impulses from the source of pain like the TMJs or the muscles of mastication or the oral cavity will now start releasing inflammatory neurotransmitters in the tissues supplied by them. This will cause a feeling of swelling to the patient. This swelling is called as neurogenic inflammation. The swelling will not be clinically visible, but the patient will feel it very prominently. The second thing that the central sensitization causes is an expansion in the sensory area of pain. I told you that the afferent neurons continuously bombard the second order neurons with neurotransmitters. There is an overflow of neurotransmitters in the spinal cord. These neurotransmitters are picked up by second order neurons that are actually carrying information from the first order neurons that are coming from the head and neck area, from the area of the back, from the scalp, from the occipital region, from the eyes. And now they transmit these neurotransmitters that were carrying signals of pain to the cortex. The cortex gets confused. It feels that the pain is coming not only from the joints, the muscles of mastication, but also from the head and neck region, from the occipital region, from the scalp and whatnot. This is what this patient is having. So, we narrow down to two causes of swelling in this patient. One, an intracapsular cause. Second, chronic centrally mediated myalgia causing central sensitization and neurogenic inflammation. Let's move ahead.
So finally, जो इस रीजन का पेन था इस साइड का बहुत ज़्यादा बढ़ गया था, स्वेलिंग भी आ गई थी काफ़ी, धीरे करके स्वेलिंग और स्ट्रेन दवा से तो चला जाता था बट वो परमानेंट ठीक नहीं होता था. सो फाइनली मतलब ये है कि जॉ का जो है वो MRI में क्लियर हो गया, बट स्टिल पेन जो है वो अभी भी इस रीजन में पूरे में।
ठीक है। The patient has finished with his history without interruptions. He told you whatever was bothering him most, whatever he thought was most important, and in the chronological order he remembers. We get two things from this history now. Our provisional diagnosis is already there. The current problem is chronic centrally mediated myalgia. He also has given us a hint to the source of the problem, probably his TMJs, since he was complaining of swelling that was associated with mastication. Now we will ask leading questions to confirm our provisional diagnosis or prove it otherwise. So let's begin.
ये पेन 24 घंटे बना रहता है क्या?
नहीं मैम, ये सीजनली भी होता है कभी कभी, या कभी कभी बेवजह भी हो जाता है, और कभी कभी बहुत ज़्यादा भी हो जाता है, कभी कभी अपने आप ही कम भी हो जाता है। सो ऐसा कोई पर्टिकुलर वो समझ नहीं आया जिसको करने से मुझे ऐसा फील हुआ।
ठीक है। किस चीज़ से बढ़ जाता है?
जैसे मैम काफ़ी जो बारिश के मौसम होते हैं उस टाइम मेरा पेन बहुत ज़्यादा बढ़ जाता है, या जब मौसम चेंज हो रहा है, इंटरचेंज हो रहे हो सीजन्स, उस टाइम प्रॉब्लम बढ़ जाती है, या जो सर्दी का टाइम होता है उस टाइम स्ट्रेन बढ़ जाता है, पेन नहीं बढ़ता बट स्ट्रेन बढ़ जाता है। सो इस तरीके से वो कंटिन्यू कहीं ना कहीं परमानेंट नेचर में रहते ही है कुछ ना कुछ।
ठीक है। मुंह बड़ा खोलने से बढ़ता है क्या?
नहीं मैम, मुंह बड़ा खोलने से या कांस्टेंट बंद रखने से तो ऐसा फील नहीं होता है कि बढ़ रहा हो पेन, बट हाँ उससे ये रहता था कि खोलने के बाद इस जगह पे स्वेलिंग थोड़ी थोड़ी आ जाती थी, और उसके अलावा बंद करने में कभी कभी लगता था जैसे मुझे दोनों जॉ बंद करने में थोड़ा प्रेशर ज़्यादा फील हो रहा है, जैसे अपने आप जॉ ओपन करने में मुझे ज़्यादा कंफर्टेबल फील होता था, बट अगर मैं कुछ टाइम कुछ मिनट्स के लिए अगर उसको क्लोज भी करता था दोनों दांत मिला के, तो मुझे एक प्रेशर यहाँ पूरे में इस जगह फील होता था।
ठीक है, ठीक है। कड़क खाना खा पाते हैं इजीली?
नहीं मैम, बहुत ज़्यादा अगर कड़क हो तो जॉ के अगर पीछे वाले दांतों से खा रहा हूँ तो एक बार को खा भी लूँ, लेकिन आगे वाले दांतों से मैं सॉफ्ट जैसे रोस्टेड चने होते हैं वो भी नहीं खा पाता।
When you ask leading questions, ask about the duration of pain. It helps you distinguish intermittent pain from constant pain. Only constant pains will cause chronic centrally mediated myalgia. So here is your chance to reconfirm whether it is chronic centrally mediated myalgia or not. This patient has chronic pain that is constant over past 6 years or so. The next question are the aggravating factors. The aggravating factors take you to the current source of pain. If the patient tells you that it is the seasonal change that is causing him pain, it is the cold or the heat that is causing him pain, stress or menstrual cycle that is causing him pain, do not ignore these points. These are the factors which will increase chronic centrally mediated pain. So the current source of pain for this patient is due to chronic centrally mediated myalgia. If the patient himself tells you that the pain increases on mastication, on opening wide, on moving jaw to a particular side, then the source of pain is inside his temporomandibular joints, that is sending continuous pain impulses to the central nervous system and causing this pain cycle to continue. In our patient, it seems that the current problem is his chronic centrally mediated myalgia and associated pain, and probably the TMJs are fine now. His complaint of swelling on opening wide is typical of retrodicitis. Remember, swelling that appears on function will be from intracapsular source. A swelling from chronic centrally mediated myalgia will be persistent. It might increase a little bit more on function, but a swelling that is typically related to opening mouth is more so from his temporomandibular joint. So this next sentence gives us a clue that still the temporomandibular disorders might not have completely healed. His complaint of inability to close mouth completely is also typical of retrodicitis, of effusions, because the patient cannot seat the condyles in their proper position for the teeth to seat completely. his complaint of inability to bite from the front teeth is typical of pain in inferior lateral pterygoids. Again, look at the fingers of the patient. He is pointing out at the temporomandibular joints while he speaks about appearance of swelling on opening or pain when closing the jaw. So, the temporomandibular joints are not completely healed, though the current source of pain is actually chronic centrally mediated myalgia.
सेकंड, पहले कभी कान के आसपास से कटकट की आवाज आती थी क्या?
जी मैम, पहले मतलब काफ़ी टाइम तक लगभग 2-4 महीने एटलीस्ट कम से कम आती रही थी। तो मुझे डोगा भी गया था, बट वही इतनी ज़्यादा इन्फॉर्मेशन नहीं थी तो मुझे समझ नहीं आया कि एक्चुअली मुझे लगा नॉर्मल ही है।
दोनों ही जॉइंट्स के आसपास से आती थी या किसी एक पे?
मैम आती दोनों से ही थी, बट मेजरली इसी पोजीशन से ज़्यादा आती थी और ये अभी भी कभी कभी आते रहते। सपोज अगर मैं इस साइड से अगर थोड़ा बैलेंस करने की थोड़ा प्रेशर फील करता हूँ तो मुझे थोड़ा रिलीफ मिलता है, बट वही कट कट की आवाज़ आती है।
History of clicking indicates disc derangement disorders, anatomic variations, adhesions, adherences, various problems like capsular laxity. When are the complaints of clicking relevant? When the clicking precedes the pain problem, probably the pain actually started inside the joints and later set in the pain cycle. This patient reports pain that started 4 months after the clicking problem. This re-emphasizes the original source of pain as the temporomandibular disorders and helps us point out the need to examine the temporomandibular joints first during clinical examination.
अभी दोनों तरफ से आती है?
हाँ।
ठीक है। इसके अलावा हेडेक्स?
हाँ रहता है काफी।
किस साइड?
ये इस रीजन में रहता है और यहाँ से इस रीजन में रहता है।
ठीक है।
ईयर के पास।
ये मॉर्निंग में ज्यादा रहता है या इवनिंग में?
इवनिंग टाइम पे ज्यादा रहता है।
ठीक है।
तो मुझे एक्चुअली थोड़ा एंजाइटी का भी इश्यू है, तो उसकी वजह से मुझे थोड़ा सर्वाइकल का इस साइड का मुझे बताया है कि अभी सिम्टम्स माइनर स्टेज पे ज़्यादा कोई इश्यू नहीं है। सो कभी कभी वो रीजन से भी होता है, बट स्टिल पेन तो इस ईयर के आसपास पूरे इस रीजन में होता है।
History of headaches and their temporal relationship helps us in knowing if parafunction is present, helps us in knowing if the patient has daytime parafunction or nighttime parafunction, and also helps us in deciding if nighttime appliances will work or physical self-regulation will work more. A patient who reports early morning headaches has nighttime parafunction and overnight appliances will help this patient. A patient who has daytime parafunction will complain of headaches that start late evenings. In this patient, besides the nighttime appliances, you will have to institute physical self-regulation techniques vigorously. You will have to ask this patient to take soft diet, take smaller bites, have slower chewing and restrict the mouth to painless range, plus keep the lips together and teeth apart, and keep an eye on any of the muscular activity that involves making the teeth meet besides swallowing or chewing. He is advised to keep an eye on his head and neck posture and do not allow to make his teeth meet other than in swallowing or in eating. Stress and anxiety are not irrelevant complaints. Stress and anxiety both lead to an increase in parafunction, especially nighttime parafunction. You have to institute nighttime appliances in these patients. Stress and anxiety also are important because these patients might be taking some medications that have parafunction as their side effects. So you have to caution the patient against them and he has to get the medicines reviewed.
ठीक है। इसके अलावा कोई आंखों के पीछे दर्द या रेडनिंग ऑफ आई या स्वेलिंग ओवर वन साइड ऑफ फेस या बोथ साइड्स ऑफ फेस?
मैम आंखों का था अराउंड जब ये शुरू हुई थी चीजें, जॉ का जो इशू हुआ था उसी टाइम बॉडी एक्ने जो हुआ था उसी टाइम हुआ था पहली बार, और उसके बाद आंखों में सॉइलिंग और ड्राइनेस रहती थी।
Autonomic symptoms: dry eyes, reddening of eye, tearing of eye, running nose, feeling of swelling. These all are autonomic complaints that the patient might have along with his brain problems. remember that for these complaints to be of some significance, they are present only on the side of pain and they increase with increase in pain. So they have to have relationship with pain and are related on the side of the pain area.
और कोई half side head एक होता है, anything that you would want to add?
मैम एक्चुअली जो पेन होता है हेड में वो इसी रीजन में होता है, इस रीजन में जो रहता है, इस रीजन में वो मेजरली इसी पोजीशन पे रहता है।
ठीक है।
इस साइड मुझे पेन बहुत रेयर चांसेस में होता है, कभी हुआ तो हुआ, अदरवाइज जो है मेजर कंसर्न वो इसी रीजन है।
ठीक है। अगर अपन एक स्केल लें 0 to 10, जो पेन स्केल हो, 0 मतलब बिल्कुल भी पेन नहीं, 10 मतलब बहुत ज़्यादा पेन है, तो अपना पेन अभी किस रेंज में है?
मैम अराउंड 8।
अराउंड 8, ठीक है। और कड़क खाना अभी अपन खा पा रहे, नहीं खा पा रहे?
नहीं मैम,
नहीं खा पाते, ठीक है।
Visual analog scale. The pain scale helps us to understand the level of pain that the patient is feeling. The 0 mark on the pain scale means that the patient has no pain, and the 10 mark on the scale means that the patient has unbearable pain. When the patient rates the pain to be 8, you can understand that it is nearly unbearable for the patient. The pain scale will help the patient compare the pain from day-to-day basis and will help us in comparing the progress that we have attained over appointments.
इसके अलावा स्लीप पैटर्न कैसा है? नींद अच्छी आती है?
मैम हाँ, नींद तो आई गेस ज़्यादा ही बोलूँगा मैं, एवरेज से ज़्यादा ही आती है।
एक बार माउथ ओपन करें। ओके, हाउ मेनी फिंगर्स कैन यू पुट इन?
4।
Just put in the fingers. ठीक।
मैम ईयर में भी कभी कभी ऐसा यूजली इसी रीजन में होता है कि ईयर ड्रमिंग जिसको बोलते हैं, कभी कभी कान में बीट जैसी साउंड आना है, ऐसा कुछ, या कान में जैसा फील होने से बंद है, जैसे कान जैसे इसको बोलते हैं बंद हो जाता है सडनली, जैसे कभी पानी चला जाए उस हिसाब से। सो वो भी फील होता है कभी कभी कि ईयर ड्रमिंग हो रही है, या कुछ माइनर सेकंड्स के लिए या कुछ सेकंड्स के लिए रहते हैं, देन फिर वो नॉर्मल हो जाता है।
ऐसा कितना फ्रीक्वेंटली होता है?
मैम ये कभी कभी तो महीने में 1-2 बार होगा, कभी कभी दिन में ही 3-4 बार होगा।
अच्छा, ठीक है। सीटी भी बजती है कान में?
मैम जैसे हम किसी तेज साउंड को काफी टाइम तक सुनते हैं तो कान में एक बीट जैसी साउंड आती है, सुन जैसी, सो वो कभी कभी सडनली फील होती है। ठीक है।
वो या तो दिन में एक आध बार होता है, या कभी
कभी दिन में 1-2 बार ही होगा, और कभी कभी महीनों में ही नहीं होता कभी कभी।
When you are asking leading questions, the last questions to ask are about sleep disorders. This patient doesn't have it, but if a patient has sleep problems, these usually increase the pain problems. If they have sleep apnea, snoring problems, they might well be contributing to his pain. The next in order is to ask if he wants to add anything more. Here the patient gives us a history of tinnitus, a ringing sound in the ear. Now tinnitus can be because of 3 reasons. 1, because the ENT reason. The second can be because of the pain pathways, the neurologic pathways. And third can be because of disc derangement disorders. When the disc is displaced and the condyle pulls a ligament called as pinto ligament that pulls the middle ear with itself, and hence the patient has a decrease in hearing capacity. The sounds from the external environment are heard less, and so the patient can hear a humming sound that comes from inside his body, or sometimes a throbbing sound because of blood vessels around. For the tinnitus to be significant, it is to have a positive relationship with pain. The tinnitus should increase with pain, but no promises. We can, in a very few % of cases, treat this tinnitus with repositioning appliances, but most of the times an effort to treat tinnitus with appliances fails. The presence of tinnitus, however, also indicates at presence of intracapsular problem and emphasizes us examining the joint during the clinical examination. So as you go through the history of this patient, you will find that none of his complaints are irrelevant. You have to pay heed to all the complaints that the patient has, and when you know all the disorders and their clinical presentations clearly, each sentence will have a meaning and you will narrow down to a provisional diagnosis. The provisional diagnosis here is chronic centrally mediated myalgia. The cause seems to be some intracapsular disorder that this patient has. We will now move ahead to clinical examination and treatment plan. Thank you. The next in order after provisional diagnosis is clinical examination. The history taking will give you the provisional diagnosis, and the provisional diagnosis will tell you what to examine first. The provisional diagnosis we have had in this patient is chronic centrally mediated myalgia. This pain disorder has its source in brain. So there is nothing to palpate in the muscles or the joints, but probably it was caused due to a joint problem that preceded the pain problem. So we have to go ahead and palpate the joints. When we check the joints, we have to ask the patient to clench his teeth and open to the maximum range possible. We check for joint sounds, deviations and deflections. Do not pay a lot of attention to deviations and deflections because they may not be very rigidly associated to any of the temporomandibular disorders and might also be because of muscle disorders. So what we really have to check is joint sounds and the range of motion. We found coarse crepitus with the right joint of this patient, indicating disc displacement without reduction or osteoarthritis with his right joint, and reciprocal click with his left joint, which indicates disc displacement with reduction with his left joints. There was tenderness over his joints, which indicates that this might be giving him continuous pain input still. To complete our clinical examination, we have to do functional tests and muscle examination. Functional tests are done to distinguish between intracapsular problems and extracapsular problems. The patient history does a better job. Functional tests are more important in acute problems and give more promising results in acute problems. In chronic problems, it is the patient's finger which will help you distinguish if the problem lies in the joints or outside. The provisional diagnosis in this patient has already told us that the current problem is actually chronic centrally mediated myalgia. So the source of his current pain is his brain. But still we need to palpate the joint because we understood that the problem might have already started in the joints. Muscle examinations are not given a lot of weightage in my practice because muscles will almost invariably be positive to palpation in all the muscle disorders. Except in acute temporomandibular intracapsular joint disorders, you won't have a lot of muscle symptoms. But in all chronic disorders, starting from local muscle soreness, myospasms, chronic centrally mediated myalgia, and trigger point pains and fibromyalgia, the muscles will almost always be positive to palpation. The only thing that you have to look for are trigger points. If you find trigger points in the back and head and neck muscles, which when palpated or pressed lead to an increase in pain, you confirm the presence of an additional disorder in this patient, which is trigger point myalgia. The only significance this finding carries is that now this patient has to have physiotherapy of the head and neck area also besides your treatments. Oral examination is done last in the order of things just to avoid biases and confusions. During oral examination, we check the range of opening, deflections and deviations, and presence of attritions, effractions and a number of things. Remember that none of these findings relate definitively to any of the disorders. So overemphasizing them will create a lot of problem for you. The range of mouth opening will tell you whether it is an intracapsular or an extracapsular disorder, whether it is disc displacement with reduction or without reduction. A soft end feel means that the problem might be muscular or disc displacement with reduction. A hard end feel and a restriction in mouth opening would mean that it is a disc displacement without reduction. Deviations will tell you that the problem might be disc displacement with reduction. Deflections are found in disc displacement without reductions and in muscle problems. Sometimes in chronic pain problems where the intracapsular problem has been there for a very long time, you won't find deflections in disc displacement without reductions. You won't find deflections in muscle problems. So these examinations are not to be overemphasized because they might be misleading. Presence of attritions, abfractions, cupping will tell you presence of parafunction in this patient. Do not try to locate the first point of contact or interferences or group function and go and eliminate them. It is in most cases not going to do any benefit to you. These factors were almost always present in this patient and might or might not have contributed to the development of intracapsular or problem or chronic centrally mediated myalgia. You have to focus on the current problem, treat the current problem and see if you can do anything favorable to the source of the pain. In our oral examination of this patient, the range of opening was entirely normal, though he was a disc displacement without reduction on the right side and disc displacement with reduction on the left side. There was no deviation or deflection on opening. So as I told you, the clinical oral examination might be misleading. You have to rely on your history taking and provisional diagnosis. Heading on to the next section, that is treatment. Treatment of this disorder will have two parts: controlling the current problem, that is chronic centrally mediated myalgia, and treating the constant source of pain, that are the TMJs. Treating the chronic centrally mediated myalgia will have to be done by a few things. The first and foremost is explanation of the disorder. The patient needs to know that the original source of pain was his joints, and due to continuous pain input, now the continuous pain is coming from the brain. You need to tell him that he needs to break the pain cycle, and that can be done with analgesics. Analgesics have to be given in a time-bound manner for fixed number of days and not SOS basis. Once the patient realizes that it is the cyclic pain that is causing all the problems, the autonomic symptoms for such a long period of time, and that breaking the pain cycle is of utmost importance, he will be more compliant to the drug regimen. The next thing in order is controlling the central sensitization. Most often this will never be needed. But in case your analgesics and counseling is not working on the patient, you would need gabapentanes. These will reduce the central sensitization and the pain cycle will break. The last thing to control chronic centrally mediated myalgia is to stop pain impulse transfer from the source of pain to the brain. In this case, it is the temporomandibular joint. The patient has disc derangement disorders bilaterally. Giving a permissive appliance is going to distribute loads away from the temporomandibular joint and will allow these joints to heal. The pain impulses from the joints will stop, and this will help in stopping the chronic centrally mediated myalgia. Appliances also work by reducing parafunction. As soon as you change any oral condition in the patient's mouth, this peripheral input to the central nervous system causes inhibition. The generalized muscle activity in the masticatory muscle goes down, and transiently the patient stops clenching and bruxing. This causes an overall reduction in the loading of the joints and causes relaxation in the muscles of mastication. So, a combination of managing the true pain source and managing the chronic centrally mediated pain will solve this patient's problem, as you will see in the next video.
हाँ तर आप बताओ कितना टाइम हो गया अपने को ट्रीटमेंट करते करते?
अराउंड 2 से 3 महीने।
2 से 3 महीने, ठीक है, अभी क्या स्टेटस है अपने पेन और प्रॉब्लम्स का?
मैम पेन में काफ़ी रिलीफ है, स्ट्रेन में भी काफ़ी रिलीफ है इस एरिया में, और जो ये पेन था जो काफ़ी टाइम से रह रहा था वो कम्प्लीटली जा चुका है।
ठीक है।
और जो साइड में ये जो था सॉइलिंग वाला चीज़ थी तो वो भी अब कम्प्लीटली जा चुकी है। थोड़ा बहुत स्ट्रेन बस एक जगह रह गया है जो अभी भी फील होता रहता है, बट अभी पहले से काफ़ी रिलीफ है।
ठीक है, पेन कहाँ आ गया 0 to 10 की स्केल पे?
मैम इट्स अराउंड 1 or 2।
ओके, और वो जो कान में रिंगिंग साउंड सुनाई देती थी?
नहीं, कम्प्लीटली जा चुकी है।
2-3 महीने में एक भी बार?
नहीं,
एक भी बार नहीं। ठीक है, मुंह बंद करने में जो अपने को टाइटनेस और डिस्कम्फर्ट फील होता था वो?
नहीं, अभी नहीं होता।
ठीक है, खाना खाने में कोई प्रॉब्लम?
नहीं मैम।
फीलिंग ऑफ स्वेलिंग एक साइड पे?
नहीं मैम, अभी नहीं होता।
हेडेक्स दोनों साइड पे?
नहीं,
हेडेक्स पे नहीं।
बाकी कोई भी प्रॉब्लम नहीं।
ठीक है, बाकी कोई भी प्रॉब्लम नहीं, तो बेटर देन बिफोर
जी।
एंड वी यूज्ड ओनली अप्लायंस
यस मैम।
एंड आई गिव यू आई थिंक नो मेडिसिन्स?
नो।